Good afternoon, everyone. Today, I'll be presenting a seminar on protein energy malnutrition under the guidance of Vipul Bhaveja sir. To start with, malnutrition is a general term for a medical condition caused by improper or insufficient diet. Most often, it refers to undernutrition resulting from inadequate consumption, poor absorption, or excessive loss of nutrients. But the term can also encompass overnutrition resulting from overeating or excessive intake of specific nutrients. Measuring weight, height, or length, and the mid upper arm circumference are the most common ways of assessing malnutrition in a given population. Three indices, namely weight for age, height or length for age, and weight for height or length, are used to identify malnutrition. By using these indices, malnutrition is broadly divided into three types, that is underweight, wasting, and stunting. The WHO classification shows various growth indicators and their ranges for various terms. So if the height or length for age, weight for age, and weight for height or length, all the three parameters are within two standard deviations, within 0 to below 2 standard till 2 minus 2 standard deviation, then these parameters are considered normal as shown in the table. But if the height or length for age is between 2 to 3 standard, minus 2 to minus 3 standard deviation, then it is labeled as stunting. If the weight for age is below minus 2 standard deviation but above minus 3 standard deviation, then it is underweight. And if weight for height or length is between minus 2 to minus 3, then it is wasting. Similarly, if all these parameters are below minus 3 standard deviation, then they are respectively severely stunted, severely underweight, and severely wasted. To show this, an example is being quoted in this. In this figure, we can see that the girl aged 18 months, weighing 10 kg, mid upper arm circumference 12.6 centimeter and length 80 centimeter, which is in this figure, she is having 18-month child having 10 kg, almost normal weight. If the weight is low for age, then it is labeled as underweight. If it is below minus 2 standard deviation, then it is labeled as underweight. If the weight for length or height is low, that is less than minus 2 standard deviation, then it is labeled as wasted. And if the length or height for age is low, then it is labeled as stunted. The vicious cycle of malnutrition starts by inadequate diet, further continues to weight loss, growth faltering, lowered immunity, and increased predisposition to infections. This further continues to recurrent and prolonged illnesses like diarrhea, pneumonia, etc. And further, poor appetite and increased nutritional requirements continue and form the vicious cycle of malnutrition. And this cycle goes on. Severe acute malnutrition and moderate acute malnutrition. Severe acute malnutrition is defined by the presence of very low weight for height or length, that is the SD score below minus 3 standard deviation of median for WHO child growth standards, plus minus mid upper arm circumference less than 11.5 centimeter, or by the presence of bilateral pitting edema. Moderate acute malnutrition, on the other hand, is the weight for height score between minus 2 to minus 3 standard deviation, along with plus this other parameters may or may not be present. That is mid upper arm circumference of 11.5 to 12.4 centimeter and no bilateral pitting edema. This is classified as moderate acute malnutrition. Clinical signs of severe acute malnutrition. First is severe wasting. This occurs due to loss of fat and muscle mass. The areas to look for wasting are ribs, shoulder area, spine, and buttocks. When the wasting is extreme, folds of skin on the buttocks and thighs look as if the child is wearing baggy pants, as shown in the picture. Second feature is bilateral pitting edema. So, imbalance in energy and protein intake in children leads to low protein in the body, and the physiological changes lead to the accumulation of excessive fluid in the tissues or edema. So, this may or may not be present in these children. So, usually present in children with kwashiorkor, as seen in the picture. So, how to check for this pitting edema? To check for edema, grasp both the feet so that they rest on your hands with one thumb on top of each foot. Press the thumbs gently for a few seconds, approximately 10 seconds. Child has bilateral pitting edema if the dents remain in both feet when we lift our thumbs. So, classification of edema is mild, moderate, or severe. It is mild if limited to both feet, moderate if both feet plus lower legs or lower arms or hands are involved. And it is severe if generalized edema is there, including feet, legs, hands, arms, and face. Third feature is dermatosis. It is present in the form of hypo or hyperpigmented areas, desquamation, ulceration spreading over limbs, genitalia, groin, behind the ears, and all these features are not uncommon in children with SAM. They are usually found because of the multivitamin and micronutrient deficiencies. So, classification of dermatosis is also there: mild, moderate, or severe. Mild if the discoloration or a few rough patches of skin are seen. Moderate if multiple patches are seen on the arms or legs. And severe, as shown in the figure, that is severe is flaking skin, raw skin, fissures can be seen, openings in the skin which predispose these children to infections. Eye signs can also be seen due to vitamin A deficiency. Always examine their eyes for bite out spot, conjunctival and corneal xerosis, pus and signs of inflammation, corneal clouding and corneal ulceration. So by WHO, the recommended criteria for identification of children with SAM is, it is described according to two age groups, that is the infants who are less than 6 months of age and those whose age group is 6 months to 59 months. So 6 to 59 months of age, the criteria is weight for height or length is less than -3 standard deviation for their growth standards, WHO growth standards, and plus minus. Other parameters may or may not be present, but this first parameter is essential for the diagnosis. Mid upper arm circumference less than 11.5 centimeter, plus minus bilateral pitting edema of both feet. But meanwhile, we have to exclude other causes of the edema, that is, for example, nephrotic syndrome or congenital heart disease. Those children whose age is less than 6 months, the criteria for them is also weight for length less than -3 standard deviation, plus minus visible severe wasting, plus minus bilateral pitting edema of both feet, and mid upper arm circumference criteria is not taken for this age group. Admission criteria. So criteria for hospitalization for these children are the medical complications that they present with. For example, presence of any of the emergency signs like hypothermia, edema, persistent vomiting, very weak and apathetic look, fever, fast breathing, chest indrawing and cyanosis, extensive skin lesions, eye lesions or post-measles status, diarrhea with dehydration based on history and clinical signs, severe anemia, purpura or bleeding tendencies. So emergency signs for triage, according to which we have to perform triage of these children if they present to us in emergency. is for airway, if they are not breathing at all or gasping, if they have obstructed breathing, if their circulation is compromised, if they are in coma or having convulsions or having diarrhea with severe dehydration. So why do the children with SAM need different management than other children for these ailments? So the systems of the body begin to slow down. The systems slow down and do less work in order to allow survival on the limited calories that were being provided to the child. This mechanism is known as reductive adaptation. When a child's carbohydrate intake is insufficient, fat stores are mobilized to provide energy. Later, protein is mobilized from muscles, skin, and the gut. Physiological and metabolic changes also take place to conserve energy. So, energy in these children is mainly conserved by reducing physical activity and growth, which leads to their deficient parameters, growth parameters, as we can see, reducing basal metabolism by slowing protein turnover, reducing the functional reserve of organs, and slowing the sodium and potassium pumps in cell membrane and reducing their number. Reduction of inflammatory and immune responses, predisposing them to severe and deadly infections. So history and examination, whenever a child with severe acute malnutrition presents to us, we have to take the history for duration of any sickness that the child presents with, recent intake of food and fluids, died during the current illness, breastfeeding, complementary feeds introduction, timing, quality and quantity, duration and frequency of complaints, loss of appetite, contact with open case of TB, history of measles in last 3 months, known HIV infection and immunization. In examination, we have to focus on anthropometry for sure, that is weight, height, length, mid upper arm circumference, and plot the various growth charts for the different parameters. Look for the emergency signs needed for hospitalization. Baseline weight, baseline respiratory rate, heart rate, and capillary filling time we have to look. Sensorium, edema, lymphadenopathy, signs of dehydration if history of losses is there, signs of shock, that is cold hands, prolonged capillary refill time, weak and fast pulse. Palmar pallor, eye signs, vitamin A deficiency, localized signs of infection, fever, hypothermia, mouth ulcers or oral thrush, skin changes, and systemic examination along with signs of meningeal irritation. So essential components of care for SAM includes 10 steps, 10 important steps in which encompasses two main phases. First phase is stabilization phase and the second phase is rehabilitation phase. So initial stabilization phase is day 1 to day 2 and the transition phase, that the other phase we can label as transition phase, that is day 3 to 7. Further rehabilitation phase can be started. So first 3 steps in the management of a child with SAM is to treat and as well as prevent hypoglycemia, hypothermia, and dehydration. Along with this, this is the primary management of these children. This is done in the initial stabilization phase. Further, electrolyte imbalance and micronutrient deficiency has to be corrected throughout the management of the SAM, and infection treatment and prevention of infection has to be covered during the initial stabilization phase as well as transition phase. Other micronutrient deficiencies have to be corrected throughout the management, but iron supplementation has to be started in rehabilitation phase. Cautious feeding we have to start from day 1 only, but gradual increase is required, and keeping in mind the reductive adaptation of these children. Catch-up growth is started in the rehabilitation phase. And along with the electrolyte and micronutrient management, the sensory stimulation and emotional support has to be provided throughout the management. Further, during the rehab phase, we have to prepare them for follow-up and educate the mother or the caretaker for their management and follow-up. So, how to treat hypoglycemia? So, in any child presenting to us with any child with severe acute malnutrition who presents to us and has hypoglycemia, if conscious, then we have to try oral feeds preferably. So, give 50 ml of 10% glucose or sucrose orally or by nasogastric tube immediately. If these solutions are not available, then we can use 1 tablespoon of sugar in 50 ml of water. Then F75 feed every 30 minutes for the first 2 hours and thereafter at 2 hourly intervals. Simultaneously also give antibiotics because hypoglycemia, hypothermia and infection form a deadly triad.
I just want to add one thing here, Chandrika.
Yes, ma'am.
If you have a patient admitted with PM, PM grade 3, grade 4, where you are suspecting hypoglycemia or such patients admitted in ward, I remember we were always told that we have to check their blood sugars in the middle of the night also, because that is a time when the blood sugars are the lowest. And there have been incidences where the child was found dead in the morning, a PM child, and probably he went into severe hypoglycemia and could not be revived. So make sure that if a child with PM is admitted in the wards for rehabilitation or something, the blood sugars should definitely be checked early in the mornings also. Say about 3-4 baje, 2-3 baje, inki blood sugars zarur check hone chahiye. If Swati is there, I'm sure Swati can add on to it if she feels.
Okay, ma'am. Thank you. Simultaneously, if the child is unconscious or is lethargic or is having convulsions, so we should give 10% glucose at 5 ml per kg IV, followed by 10% glucose or sucrose 50 ml by NG tube or OG tube. So in unconscious child or with convulsions, we have to give it by IV first, then followed by NGT. To prevent or treat hypothermia, feed the child immediately on admission and then at regular intervals. Cover the child, including his head, soles and palms. Let the child sleep with the mother in close contact and cover him or her with a blanket. Stop draughts in the room. Move the child away from windows. Maintain the room temperature of around 25 to 30 degrees Celsius. In spite of this, if the child is having severe hypothermia, that is the temperature is less than 32 degrees Celsius, then give warm humidified oxygen. Simultaneously treat the hypoglycemia. Start IV antibiotics and rewarm the child. That is, provide heat by using radiation, that is radiant warmer or skin contact or convection. Avoid rapid rewarming as this may lead to disequilibrium in these children. So coming to dehydration, signs of dehydration are listed as lethargy, restlessness, irritability, sunken eyes, excessive thirst, slow skin pinch and decreased urine output. It is very difficult to determine dehydration status in a child with severe acute malnutrition, as the usual signs of dehydration, such as lethargy or sunken eyes, may be present in these children all of the time, whether or not they are dehydrated. So, along with these signs, there needs to be a definite history of diarrhea or losses and history of a recent change in child's eyes, which can very well be asked by the caretaker or mother of the child. So during the management of dehydration, before starting any rehydration treatment, first of all, weigh the child. Baseline admission weight and pre-management weight should be taken. Mark the edge of liver and costal margin on the skin and record the respiration rate, pulse rate and capillary filling time. Management of dehydration in a child with SAM. So take pre-management weight, start ORS at 5 ml per kg orally. So a child who's not in shock and received to us in dehydration is started preferably on oral feeds, and IV intravascular fluids are avoided. So ORS is started at 5 ml per kg every 30 minutes for 2 hours. ORS used in children with SAM is commonly used ORS is Resomal, that is rehydration solution for malnourished children. So measure the for 2 hours we have continued this ORS at every 30 minutes. Then weight is repeated. If the weight gain is there and clinical improvement is also there, then we continue the same management. But if weight gain is there but clinical improvement is not there, so all rehydration fluid should be stopped, and instead of this, F75 diet, F75 starter diet is started. So reassess and revise the diagnosis that what was the cause for worsening. So when we measured the weight, it was stable, it didn't change. So we increased the ORS by 5 ml per kg per hour, and every hour we have to reassess the child. But if the weight loss is there after giving ORS, then we increase ORS from 5 ml per kg to 10 ml per kg per hour and reassess the child every hour. So continue 5 to 10 ml per kg every alternate hour up to 10 hours in these children. Management of shock in SAM. So any child presenting to us, any child with severe acute malnutrition presenting to us with shock, first of all, weigh the child, give oxygen, make sure the child is warm, insert an IV line and draw blood for emergency lab investigation. Simultaneously treat the hypoglycemia, hypothermia. If received in shock, then give IV fluid at 15 ml per kg over 1 hour of either Ringer lactate in 5% dextrose or N/2 DNS. Count and record the pulse and respiratory rate at the start and count it every 5 to 10 minutes for monitoring of the treatment and worsening or improvement of the child. So if signs of improvement are seen, what are the signs of improvement in these children? These are the fall in pulse rate as well as respiratory rate. So if the pulse rate and respiratory rate fall after starting the fluid bolus, then repeat same fluid IV 15 ml per kg over 1 hour more. Then switch to oral or NG hydration with ORS at 10 ml per kg per hour up to 10 hours. And further initiate F75 starter formula. After the first IV fluid bolus, if the child fails to improve, then assume that the child is received in septic shock. Simultaneously, also, if the child deteriorates, either the child doesn't respond or the child deteriorates during the rehydration, that is, respiratory rate increases by 5 per minute or pulse rate increases by 15 beats per minute, then stop the infusion and reassess. And in both of these conditions, assume that the child has septic shock, give maintenance IV fluid only, review antibiotic treatment and upgrade the treatment according to the science and protocols that we follow. Transfuse whole blood 10 ml per kg over 3 hours. Start dopamine and start inotropes as applicable. Initiate refeeding as soon as possible and reassess the child. If improvement, then stop maintenance IV fluid and try to start F75 starter diet as soon as possible after stabilization. Further, if no improvement is there, then continue maintenance IV fluid, half normal saline with 5% dextrose at maintenance rate, or start inotropes. Correction of electrolyte imbalance has also to be followed throughout the management of SAM. So give supplemental potassium at 3 to 4 milliequivalent per kg per day, and this has to be continued for at least 2 weeks. It can easily be given by oral formulation of syrup of potassium chloride found in formulation of 20 milliequivalent per 15 ml. Also on day 1, we have to give magnesium supplementation. So give 50% magnesium sulfate IM once at 0.3 ml per kg, and a maximum dose of 2 ml can be given. Thereafter, give extra magnesium daily, that is 0.4 to 0.6 millimole per kg per day. During iron has to be started during phase 2 and not during the phase 1. Also look for overhydration. Give food without added salt to avoid sodium overload till the time the child is found fit for introduction of mixed diet. Micronutrient supplementation. This also has to be followed throughout the management of the SAM child. Multivitamin supplement. This supplement should contain vitamin A, C, D, E, and B12, and not just vitamin B complex in twice recommended dietary allowance range. Folic acid to be started 5 mg on day 1 and then 1 mg per day. Elemental zinc 2 mg per kg per day. Copper 0.3 mg per kg per day. And when weight gain commences and there is no edema and no diarrhea, add 3 mg of elemental iron per kg per day. That is during the rehabilitation phase. So all other micronutrients to be started initially, but iron has to be started during rehabilitation phase. Initiation of cautious feeding. So in the initial stabilization phase, we start with F75 diet. F75 is a special diet which has been formulated for the children with SAM. Per 100 ml of this diet contains 75 calories and 0.9 gram of protein. Along with this, it contains lactose, potassium, sodium, magnesium, zinc, and copper in the explained amounts. It is a special diet that provides 75 kilocalorie. That I told it is specially made to meet the child with SAM's need without overwhelming the body's systems. The starter F75 diet is low in protein and sodium and high in carbohydrate. So this diet is more easily handled by the child and provides the much needed glucose. So on day 1 of the management, give starter F75 diet every 2 hours. 12 feeds in, that is 12 feeds in 24 hours we have to supplement, including through the night also. So if the child is found to be hypoglycemic, then give 1/4 of the 2 hourly amount every half hour. So every half hour we have to give the feeds in 1/4 amount if the child is hypoglycemic. After day 1, increase the volume per feed gradually so that the child's system is not overwhelmed due to the reductive adaptation that we discussed in the previous slides. The child will gradually be able to take larger and less frequent feeds. So gradually we'll increase the volume and decrease the frequency of the feeds after day 1. That is 3 hourly or 4 hourly feeds will come up to. So aim is to reach till 130 ml per kg per day or 100 or till 100 ml per kg per day in those with edema. So what is the advantage of starter diet? That it promotes recovery of normal metabolic function and electrolyte balance, provides energy and protein to maintain basic physiological processes, and does not bring about rapid weight gain, which is dangerous in initial stabilization stage. So transition phase, that is day 3 to day 7. So initially we started on F75 diet, but we want the child to gain more weight, and we want to supplement the child with more protein and more calories. So after stabilization, we want to perform a transition to the rehab phase. So this transition depends on readiness of the child. So readiness is determined by the return of appetite. That is, the child easily finishes 4 hourly F75 diet. Child is taking orally. Edema starts disappearing. Child shows clinical improvement. That is, the child is more alert, smiles, and is active. Most children with SAM will reach this within 7 days of admission. That is day 3 to day 7 that we talked about. During transition phase, monitor for following signs of heart failure, because we may overwhelm the child with excess feeds. So if the respiratory in rate increases by 5 breaths per minute or more, and the pulse rate increases by 15 breaths per minute or more, so we have to slow down the transition. Further, coming to the rehabilitation phase. In rehabilitation phase, we plan to catch up the growth of the child by F100 diet. So this F100 diet has 100 calories per 100 ml of diet and 2.9 gram of protein. So compared to F75 diet, which had 0.9 gram per 100 ml protein, it has 2.9 gram protein in 100 ml, and other micronutrients and lactose are comparable. So during the starting of F100 diet, initial 2 days we go slowly, and in the initial 2 days we give catch up of F100 diet every 4 hours in the same amount as we gave the starter F75 diet, and we don't increase this amount for at least 2 days, whether or not the child is accepting it well. So on day third, on day 3 of starting catch up diet F100, we increase each feed by 10 ml as long as the child is finishing the feeds. If the child does not finish a feed, offer the same amount at the next feed. And then if the feed is finished, increase by 10 ml. Continue increasing the amount until some food is left after most feeds. Towards rehabilitation phase. So criteria to move from transition phase to rehab phases: that the child doesn't have any hypoglycemia, hypothermia, child has good appetite, that is child finishes more than 75% of the feed, has no diarrhea and vomiting, and edema starts to subside. Most children feed freely till 150 kilocalorie per kg per day, and the upper limit is till 220 kilocalorie per kg per day. Daily care. Daily care of the child involves sensory stimulation and play therapy, maintain asepsis, giving prescribed antibiotics and other medication and supplements, eye and skin care, monitoring pulse, respiratory rate, temperature, and watching for the danger signs, completion and interpretation of the daily care chart intake, which includes the intake, output, and weight and other parameters. Also involve the mothers in the care, preparation for discharge, and follow-up. So criteria for discharge for these children is, as per the child, if the child has achieved a weight gain of around more than 15% and has satisfactory weight gain for 3 consecutive days, that is more than 5 gram per kg per day. Edema has resolved, child is eating adequate amount of nutritious food that the mother can prepare at home. All infection and other medical complications have been treated, and immunization is updated. On the part of mother or the caregiver, we should confirm that the mother knows how to prepare appropriate foods and feed the child. The mother should know how to make toys and play with the child, and knows how to give treatment at home for diarrhea, fever, and acute respiratory tract infections. Also, she should be taught about recognition of signs which should seek medical assistance, and follow-up plan should be explained very well. General discharge instruction is that how to continue any needed medication, that is micronutrient and for electrolyte we should tell them. So folic acid continued for 2 weeks and iron for 2 to 3 months at home. Explain them the signs to bring the child back for assistance. That is, if the child is not able to drink or breastfeed, stops feeding, develops fever, breathes fast or has difficulty in breathing, has any convulsion, or having diarrhea for more than a day, or blood in stool. Follow-up. Plan for follow-up visits on discharge every 15 days up to 2 months. That is 4 follow-up visits should be there at least. Then monthly until weight for height standard deviation score reaches -1 standard deviation or above. If any problem arises intermittently, then visits should be more frequent until the issue is resolved. Thank you.
Dr. Arun, any questions?
Question from disease, but how we assess whited spots in the eyes in vitamin A deficiency?
Sir, they can be seen visually. They can be seen as deposits, triangular deposits on the in the eyes with the
On the temporal aspects of the eye, on the
yes, sir.
temporal aspect of cornea, and the foamy layer over these dry patches, triangular dry patches.
Yes, sir.
Have you ever seen?
So seen in pictures only, pictorial presentation only.
Because we got well-nourished children, hardly see undernourished children.
Yes, sir.
To go to Kalavati or some other government hospital.
What can be the precursor of whited spots that we should keep in mind? What all you will see before whited spots appear? Arun can tell us. Whited spots is a late manifestation of vitamin
Night
A
blindness or
deficiency.
क्या है?
What are the things which lead to that in history or maybe in examination? Arun?
नाइट ब्लाइंडनेस का सुना है कुछ वर्ड?
सर
क्या होता है नाइट ब्लाइंडनेस?
सर
Sir, conjunctival xerosis can also be seen before whiteout spot.
So you will see symptoms of night blindness, child making those tiny eyes and putting strain, especially during the evening hours. Then you see the in general dryness of conjunctiva, which can be seen sometimes. You can have those tear tests to see the tear break time, and it is also manifested as frequent blinking or itching of the eye. And when you see, you can see dryness. And then yes, the whiteout spots, the extreme form of the dryness develop, and the triangular spots. How do you distinguish between Arun between a whiteout spot and pterygium?
पिटोट स्पॉट एंड सर
टेरिजियम टेरिजियम होता है आई में
सर टेरिजियम तो सर वो कवर आई का जो मतलब कवर करते हैं सर उसमें आई का जो
पॉइंट्स ऑफ डिफरेंसेस हैं टेरिजियम स्टार्ट हो रहा है या वाइटआउट स्टार्ट हो रहा है कैसे डिफरेंशिएट करोगे
टेरिजियम कवर करेगा सर कोर्निया को वो नहीं कवर करेगा सर
वो तो बाद में करेगा उससे पहले
सर वो टेम्पोरल रीजन से स्टार्ट होगा
Sir, it is less opaque than
एक मीडियल से होता है एक टेम्पोरल से होता है
yes
one covers the cornea one does not cover the cornea
later
medial
will
temporal.
eventually overgo the yeah and you know the direction usually the whiteout spots the triangular base will towards the cornea and in pterygium it is the other way around. The triangular, the apex is pointing towards the cornea, it encroaches, the bases are on the lateral sides, outer side. Dr. Agarwal sir, any more questions for the PGs?
One question in protein energy malnutrition. How do you comment upon gross motor milestones? Just like because they were not able to hold the neck, how can we comment the child has achieved the milestone at 20 weeks of neck holding and sitting when already protein loss is there? Milestone is an important part in every examination.
yes, sir. So after rehabilitation, if they gain the milestones, then adequate development is there, but not.
Think about it, then answer. Because on the exam, when you are getting the case, you won't say to the examiner, we will assess after rehabilitation. At the moment, what you will say?
Yes, sir.
Sir, I think in case of any acute illness or where the child is acutely sick, we have an exemption that we are not able to elicit the motor milestones and for that matter, reflexes also. So either we go by the history, but yes, in history, we should be more important that there is no regression of other milestones like social or cognitive.
The mental he will
yes,
be
you're right.
achieving. Mental child will achieve. Regression of milestone makes another diagnosis. That is altogether a different entity. Only thing is mental milestone will be.
I was trying to say even one can document the regression of motor milestones because of the progressive weakness, malnutrition, muscle strength. But the other milestones, if we can elicit, if they are not regressed, then we can at least support our history that child is developmentally so and so normal. But due to this acute phase, we like to reassess the child after during rehabilitation. This is what comes to my mind.
Okay, Dr. Raman is there. He can add something.
सर फाइनली मतलब आंसर हम क्या देंगे रिगार्डिंग ग्रोस मोटर माइलस्टोन?
तो वही तभी तो बोला ना, think it over then decide and tell.
कई बार एग्जामिनर को भी इसका आंसर नहीं पता होता, वो पूछ लेते हैं जैसे सर ने पूछ लिया.
Dr. Raman is there. He can answer. Raman, बताओ भाई, मीटिंग में हो.
सर ज्यादा ना मतलब प्रैक्टिकल एक्सपीरियंस खत्म होने से बिल्कुल भी सुन ही रहा हूँ, ज्यादा बोल नहीं पा रहा हूँ बिकॉज डिस्टेंट पास्ट में लगता है ना कि मतलब there's been so many years somehow we just lost the touch with this part and I just thought
it is a very tough subject.
बिल्कुल ही वीक है.
I think now after the COVID pandemic is over, we are going to see epidemic of malnutrition. In a good class society, we are seeing malnutrition in the form of overnutrition. Obesity is gone up. And in the underprivileged society, also this thing is going to go up because of loss of members, loss of jobs, less availability of foods due to pandemic. I'm sure this is going to go up a little bit, but unfortunately, we will not be managing them in private sector. And that is the catch.
Dr. Chandrika, nice presentation. In spite of your illness, you did a good job.
Thank you, sir.
Thank you, Chandrika. Thank you so much. I think so we close the session.
Thank you, sir.
Okay, thank you.
Okay.
Thank you so much.